Our next speaker, Professor Nicola from the University of Bern, is more of the epidemiological persuasion than the immunological persuasion, and she's going to talk to us about chlamydia. Now, chlamydia, in any country that measures it, and most countries don't, absolutely dominates the infectious disease statistics. Australia's hovering at around about 80 to 90,000 diagnoses a year. And there's been some elegant modelling work done at the Kirby Institute led by David Wilson and Hamad Ali to suggest that probably we're only diagnosing 1 in 4 or less of all the new infections each year. The great unknown with chlamydia is we don't know exactly how nasty it really is. Because we've had a cure for a long time, we can no longer do natural history experiments. And I suspect Nicola will be talking about some of the great unknowns with chlamydia. Now, I'm a great fan of Nicola's. Despite her lack of veterinary training, she still has a very good bullshit meter. She is always questioning, she detests dogma, and she always keeps us on our feet, and it's been delightful collaborating with her in recent years. And as a special treat to break up the day for you, she has promised to give her talk in Swiss German. Thank you, Nicola.
Merci vielmals, Basil. Grüß euch miteinander. Okay, I'll spare you the rest of it, because the rest of it, Swiss German, is probably much to you as immunology is to me. As Basil said, I'm an epidemiologist, so this is a talk that everyone can understand. I'm really, really honoured to be here at this Kirby Symposium. I'm very, very grateful to David Cooper and John Kaldor and Basil and all of the people at the Kirby for having thought of me and invited me here. It's certainly the most prestigious group of people amongst whom I've been honoured to speak. So I hope I can keep up with the style and the capacity of all the previous speakers. As Basil said, my main passion is chlamydia and has been for about 20 years now. When I came into the chlamydia world, I was led to believe that everything had more or less been sorted about chlamydia and we knew everything that we needed to know and all we needed to do was to screen and treat to get rid of it. But here I am 20 years later. I think there are certainly far more questions than, that have been raised than we have managed to answer in the last 20 years. And I'm going to talk about what I really think is important about intervening in any kind of infectious disease is about weighing up the evidence about whether we are doing more good than harm. And I want to try and look at that from the point of view of where I've come from Europe and from developed countries, but extending that to lower and middle income countries. I'd like to acknowledge people who've helped me from my team at the University of Bern. I have a fantastic team of mathematical modelers without whom I wouldn't know a lot of what I'm going to talk about today. But also amazing luck to have been collaborating with people also in the Netherlands who did a big trial of chlamydia screening, and also, of course, my friends and colleagues here in Australia, many of whom work on the ACCEPT trial, which is an ongoing trial of chlamydia screening, and many people at the Kirby Centre who've been really, really kind and collaborative over the years, and look forward to working with you in the future, if I'm allowed to, by the end of what I'm going to say today. So I sort of asked myself, when did chlamydia begin? I said it seemed to have all been sorted when I came into the chlamydia world. And the reason I ask myself the question is not because I'm an evolutionary biologist, but because I suspect that it started sometime before 1963, but probably did start somewhere along with sexual intercourse. However, the way that people talk about chlamydia and its inevitable and inexorable rise, as Basil mentioned, is much as though it's a disease that only actually appeared or was discovered or invented in the last 20 or 30 years. But what you can see from this slide is also, as Basil had actually basically given my talk already, so bye, that it is far and away the most common infectious disease that in most developed countries that is diagnosed. Partly that's because we're looking for it more, but way outweighs the other sexually transmitted, bacterial sexually transmitted infections that we deal with. And so that's why we need to know about it, we need to understand about it, we need to know what to do about it. So what I'm going to talk about is to present a very brief overview of some global epidemiology of chlamydia infections. Talk a little bit about complications as we need to, and then I'm going to spend most of my time talking about chlamydia control methods, what methods there are, but I'm going to focus on the population control methods, and by that I really mean screening programs, and then draw some conclusions and see about if we can think about ways of taking on what we know so far. So here is a picture of WHO regions. It's nicely separated into color-coded regions. And what I've put up is what WHO estimated in 2008 was the annual incidence, so the number of new infections with chlamydia occurring yearly across the globe, that they put at somewhere around 100 million. This is their geographical distribution. This one in Africa, in case you can't see it, says 8.3 million, 3 million in North Africa and Middle East. The bulk of infections are in the Western Pacific region, which Australia is honoured to belong to, joining China, which presumably dominates the vast majority of these figures. But also, as you're going to see is important, are these South Pacific islands. Now, we're talking about a sexually transmitted infection, but just to remind you, the people who are vulnerable to sexually transmitted infections and tend to have highest prevalences, mostly adolescents and young sexually active adults, depending on, and those clearly with more sexual partners, lends to transmission of infection. And depending on the country in which you live and the society in which you live, some minority ethnic groups, men who have sex with men and sex workers in some countries, but not in Australia, are particularly vulnerable to chlamydia infections. So again, with these are often marginalized populations who tend to have poor access to health services. Now, when I was putting together this talk, what people want to know, but is how common is it? Just sheer numbers can't tell you how the prevalence of an infection in a particular population, because the sheer numbers don't take into account population size. What also is rarely taken into consideration is if you want to know the prevalence of an infection in the general population, you have to have survey data that include people who are in the general population. And where many sexually transmitted infection surveys take place are in clinic-based settings where you get the impression that they are extremely common sort of prevalences of sort of 10, 20, 30%, but they come from clinic settings. But when you look at a random sample of the general population, you find in many, many countries that you have levels sort of fairly consistently across many countries of around sort of 5% or below. So sort of 3% is the sort of typical value for a sexually active population aged 15 to 24 in the general population. So that sounds quite low. What surprised me, so these data, the ones from Europe and other high-income countries do come from a systematic review of surveys done in the general population with random population sampling methods. So these are genuine population surveys. It's difficult to find those sort of surveys in many countries. So what I have used for other countries were to find surveys that were done in close to population samples. And by that I included pregnant women, and I included women enrolled in consecutive samples from antenatal or family planning clinics. What surprised me was that in countries in several parts of Africa, Malawi, Uganda, Zimbabwe, these countries, the prevalence rates are as low or if not lower than they are in countries in Europe and other high-income countries. And these aren't isolated. There are other examples of surveys done in these countries which show that these are not freak studies. What was also interesting about Africa was that in South Africa, the prevalence estimates are consistently higher in many other sub-Saharan African countries. And then coming across to the Western Pacific region, Australia and New Zealand come within this main body of countries. But what is really extraordinary, and I think being increasingly recognized, but really hasn't been looked at very much until now, is that in the South Pacific Islands, these are all surveys that have been done in pregnant women or in genuine community-based samples. And they are showing prevalence rates, so there's the current infection rates with chlamydia amongst women aged 18 to 24 of around 20 to 30%. The exception is this one in the Solomon Islands, but these survey findings are not atypical. And this is something I'm going to come back to when we talk about chlamydia control. So of course the other thing, the reason we worry about chlamydia is because of its association with reproductive tract complications, particularly in women. And of course, the end point of that becomes tubal factor infertility. And so what we're interested in is what is the association between chlamydia and the reproductive tract complications. So fortunately, there has been a worldwide survey of the burden of infertility done as part of the Global Burden of Disease Project. And this group of investigators estimated from demographic and health surveys. So these are health surveys that are done at household level in representative samples of the population. What was the prevalence of primary and secondary infertility? And by primary infertility, they mean a couple that's been together for 5 years, trying for a pregnancy and not getting pregnant. It's a standard demographic definition. And I think what I was, again, surprised that the actual range of infertility is really basically 1 to 3%, which is a very, very narrow range to be seen internationally. And therefore, when it's such a narrow range, you would think that there may not be very much correlation at this country population level between chlamydia infection and infertility. But I think you'll agree, I didn't draw a trend line through these, but I think you'll agree that all these countries with the highest chlamydia prevalence in the Western South Pacific are those which report the highest rates of infertility as well. So, of course, these are population level data. They could be confounded by many, many things, but at this population level, there seems to be an association between the prevalence of chlamydia in the general population and reports of primary infertility. Now, what are we going to do about it? First, when we decide what we want to do to control any disease, we have to know what we're trying to control. We're infectious disease specialists here, so when we look at an infection like chlamydia, we want to know what it does. It goes up, if you're a woman, up into your tubes, causes pelvic inflammatory disease, inflammation in the upper genital tract. And then, if you're unlucky, it won't resolve, it will cause tubal damage. And then the possible endpoints of that, the most devastating ones, are to have an ectopic pregnancy if you get pregnant, or to not be able to get pregnant, to have tubal infertility. So if we want to intervene to control chlamydia infection, we're doing two things. The first is that we're trying to prevent infection before it gets up to your tubes, so prevention of ascending infection. And then a very, very important feature of chlamydia, which is where I wish that my immunology were better, is that chlamydia doesn't cause very lasting immunity, so you can get infected after you have received treatment. It appears that once you've received antibiotic treatment, you become susceptible very, very quickly. But if you have an infection that you allow to clear naturally, there is more lasting immunity after a natural infection. So it means that if we're intervening, we are intervening to prevent transmission of infection, but we have to remember that if we treat people and cure them, then we are making them susceptible to become reinfected. And that's an important theme that we need to think through when we're talking about control. Now, of course, when we refer to infertility as a long-term complication of chlamydia infection, and that's because by the time it manifests itself, often in women who are in their 30s and trying to get pregnant, that is because they've been using this really, really clever invention called contraception for the last 20 years. And if you shift this, all of this this could be seen as a timeline as well as a pathogenesis line, but it could all be shifted right up to here. And these are women who may actually have become fertile very, very soon, infertile soon after they acquired their chlamydia infection. And I think that's something that we quite often forget, but we have to take it into consideration because it means that it's very, very difficult to observe the endpoints in which we're truly interested. Now, the other important thing, of course, is that infertility is a devastating condition for any couple to be experiencing. But we want to know really how common it is. If we're going to do a population-level intervention to control chlamydia, we need to know, if you have a chlamydia infection, what is your probability of ending up infertile? And of course, that is something that you can't do in a natural history cohort when you have to treat an infection when you find it. And so we don't have direct answers of how to get from this point of having chlamydia infection, how likely are you to become infertile? But we have indirect source of information that we can look at, and so we can find out the probability of chlamydia infection. We can look at infertility surveys and find how much of that is due to tubal factor infertility, and we can also do serological surveys in women who do have tubal factor infertility to find out how many of those have previously had chlamydia infections. If we then do some very, very clever statistical things using Bayes' theorem, which I won't go into now, we can come out with an estimate that combines these individual estimates that you can get of this indirect information. And the answer is that the probability of tubal factor infertility, if you have had a chlamydia infection, is of the order of 1%. It's quite a low probability across your reproductive lifespan that if you have had a chlamydia infection, you're going to end up infertile from it. But I think it's important to have that in mind, because the proxy that we use for tubal factor infertility is pelvic inflammatory disease, which is, of course, much more common. Estimated about 10 to 15% of women with an untreated chlamydial infection will have PID, but a very small proportion of those will actually progress and become infertile as a result of it. Now, here's where my modelling colleagues have really, really helped me out, because I told you that what we're interested in doing when we want to control chlamydia are two things. We want to prevent ascending infection, and we want to prevent transmission, prevalence. And those two things are going to have different effects on the control of chlamydia. But you won't ever be able to separate out those when you just observe what's going on. But what you can do if you use mathematical modelling is that you can separate out parts of your model to count the proportion of infections that are occurred through direct prevention, that's a result of treating an asymptomatic chlamydia infection and stopping it from developing into PID, and you can count the proportion that is indirect prevention that comes from preventing transmission. And it turns out that if this is the whole number of infections, these are PID episodes that are prevented, if you separate those out into the directly prevented ones and the indirectly prevented ones, At the beginning, if you start off and say you haven't got any control, the early infections prevented are going to be those prevented directly in individual women. But over time, the proportion that are prevented just because you reduce exposure to chlamydia overtakes that and then dominates the picture. And this crossover point happens at some point. At an earlier point, the observant amongst you will see that this line dips between the line of having 0 in PID cases, which means there's a potential harmful effect. You're actually causing more PID cases, and that is the result of treating infections, making women susceptible again, then getting reinfected and getting PID. Now, this effect you would never, ever observe because it's always outbalanced by actual PID cases that are getting prevented. But this is something that you have to think of, is that when you treat a woman with PID or woman with chlamydia, maybe you're not doing her a favor, but you would never know which woman that was. So let's just think about what interventions do we have at our disposal. There are a range of interventions. The one that we do mostly is that we do case management and case finding by the people who sit in front of us in our clinics. What I'm going to focus on are these two that are aimed at the population level. Primary prevention, which we talked about in the debate and doesn't seem to get a very good press. And then so I'm not going to bother much with that. And then I'm going to move on and talk mostly about chlamydia screening programs. Here is my only link with making sexually transmitted infection like chlamydia have something to do with HIV. But HIV we are very grateful for because it shows that primary prevention actually works. As you heard from the panel discussion, that at the time that HIV was getting really, really scary and countries had massive programs telling people they were going to die if they didn't use a condom, people started using condoms and they changed their sexual behavior. Now, coincidentally, at around that time, many developed countries also got their act together to provide chlamydia testing and sexually transmitted diseases clinics, and this decline in chlamydia notification rates in Sweden coincides with the national prevention campaign, and that picture is seen across a range of developed countries that have collected data, and it's not just chlamydia. Gonorrhea went down, syphilis went down, PID went down as well, and it's widely agreed that HIV, the changes in behavior that resulted from HIV were able to reduce levels of bacterial sexually transmitted infections. So let's talk about screening now. And before we talk about what the effects are, I want to do my didactic part of the lecture, which is to impress upon you that when we talk about screening, we have to know what the definition of screening is, what it is that we're doing, and how to weigh the evidence. So the definition of screening comes from your Australian population-based screening framework, adapted from a WHO definition, is that it's a presumptive diagnosis of an unrecognized disease using tests and intended for all people in a target group who don't have any symptoms. So you're targeting anyone most of whom do not know and may not have any suspicion that they have any infection or any disease at all. This next quote I find one of the most important to talk about when we discuss what we're doing with screening. It comes from Muir Gray, who led the National Screening Committee in the United Kingdom, and he says that all screening programs do harm. We could stop it there, but he has a get out. Some do good as well, and of those, some do good at reasonable cost. The reason that it is worth thinking about screening in this way is because screening sounds very, very attractive. You're identifying undiagnosed disease, you're treating it, and you're preventing long-term conditions. End of story. It's great. What I want to talk about is to bring a word of caution into here and think about, through this, about we really have to think about whether we are doing more good than harm, and that's what I'm going to try and lead you through now. So a little bit more about assessing the appropriateness of a condition for screening. You have to fulfill certain criteria about the importance and frequency of the condition, how are you going to test for it, how are you going to treat it, and what program are you going to put in place to make sure that it is sustainable. This is of vital importance for an infectious disease that doesn't cause immunity, that causes reinfection, is that there is no point in saying you need to be screened for chlamydia and doing that once off when you have a young sexually active population who is not going to stop having sex because you diagnosed and treated them with chlamydia, but they may very well not ever get another chlamydia test if you don't have a sustainable program in place. And one major criterion is that if you're going to implement any program, you should have evidence from high-quality randomized controlled trials that your screening program does what it says on the packet. And here is one of the things that I find terribly sad about sexually transmitted infections, and probably chlamydia in general, considering how common it is that we don't seem to live up to the standards that are required for other diseases for which we implement screening, and in our demand for high-quality evidence before we leap forth and start implementing our interventions. So if we think about chlamydia, it is a great disease that fulfills all of the criteria for most of the criteria for should you do a screening program. This is where we come on to its clinical epidemiology. It's common, it has serious implications, most of it is asymptomatic, and it lasts a long time if it's untreated. We have very, very accurate and sensitive tests available, and we can treat it with antibiotics. So there you go. We should screen for it because we can do all of this, we can intervene. One of the things that you will find out from mathematical models, this is done by one of my postdocs, but easy to replicate, is that if you put in the asymptomatic nature, its long duration, and then what happens when you test and treat, you will see that any model will predict that even at very modest levels of screening, you can reduce prevalence over time. At the sort of levels that we would like to achieve, sort of 25 to 50% or more per year, all these models predict that we could be getting rid of chlamydia within 10 years. Now, sadly, we have a look at reality, and we know that that is not the case, because we know that there are places that have been doing chlamydia screening for that long, and we know they haven't got rid of chlamydia. So what else is going on? There are factors that mitigate against screening and screening programs. And one of these is that, apart from sustainability, is this question of limited immunity after treatment. And here is a lovely study done by Jennifer Walker in Melbourne, where following women who have been screened and treated for chlamydia, and then repeatedly testing them over a period of up to 18 months, and showing that here, by a year, 25% of them have had a repeated infection. That's an awful lot of people who you have treated for them to be getting reinfected within a year. And the likelihood is that in any chlamydia control program at the moment, very few of those are actually going to get another test in a year and find out that that's what's happened to them. So actually they remain infected, they are infecting others, and they are at risk of having reproductive tract damage again. Now, and not to forget, but actually we do always forget, that there are direct harms of screening, of telling someone that they have chlamydia. Maybe they don't actually have chlamydia. No diagnostic test is perfect. And if they do have, if they've been told that they have chlamydia and they go and tell their partner, then they have a fair chance of their relationship breaking up. And if they're in a potentially violent relationship, there is also a risk of intimate partner violence. And those are things that are really, really poorly investigated in relation to sexually transmitted infections and telling partners about STIs. And I think that we need to pay more attention to those. So how are we doing? Do we have the evidence to say that we should have control programs? So now I'm going to take you to these two aims in turn. The first is preventing ascending infection and PID. And here we do actually have 4 randomized controlled trials identified in a systematic review, so we're fairly sure that there aren't, that this is the totality of randomized controlled trials in the prevention of PID. Interestingly, they all, and reassuringly actually, they all show an effect that favors screening. I think one nice thing that you see quite often over time with RCTs is that the effect size, though, tends to diminish over time. So the earlier trials tend to show much larger effects than more recent trials, and that's because often methodological conduct of trials improves over time. But if there is, these trial results are all statistically compatible, and you can combine them in a meta-analysis to give a pooled result to suggest that there is a reduction of about 35% in individual women's risk of PID in the year after having had a test for chlamydia and being treated if she was positive. Now remember that the uptake in most of these trials is very, very high. So that is a sort of maximal effect that you could expect if these are unbiased results. And that would be after a year. But no trial yet has looked to see what is the effect of doing screening repeatedly year on year, and whether that effect is 35% per year or whether it plateaus out. We just don't know. We know that it's 35% after in the year following screening. Now, coming to the transmission bit, which I showed you, is that the indirect prevention of chlamydia is the one that dominates. It's preventing transmission, so you reduce prevalence. What evidence do we have about that? Now, this is sadly where we just do not have good trials. This is a trial that was done in the Netherlands. It's the best trial that has been completed so far. It was a cluster trial done in 3 regions where they sent out invitations yearly to all adults aged between 15 and 29, and invited them to collect specimens at home and mail them and be tested and treated. So that's a systematic screening program, and it was done over 3 years. The bottom line is that the uptake was abysmal, much, much lower than we've got in any of our home screening pilots. So it was a maximal 16% in the first round and went down to under 10% by the 3rd year. And possibly not surprisingly, compared with the usual care that women were getting, the positivity rate of chlamydia didn't change at all over the 3 years, and in comparison with the control group, which just got, those people just got screened once at the end of the trial. So from this trial, we don't have any evidence that chlamydia screening reduced positivity, but we cannot rule out the fact that it just didn't have high enough uptake to have any impact at all. Now, this next trial is the trial. It's the ACCEPT trial. It's going in Australia at the moment in 54 rural towns across 4 states of Australia. Many of you know of this trial and are, in fact, involved in it at the moment. This is an opportunistic screening trial, so it's for women and men who are going to general practices. And this is more like real life. This is how chlamydia testing takes place in practice. It is... The aim is to look at a reduction in estimated prevalence. What it's been able to show so far is that compared to a control group where around 10% of people are getting tested, you can increase testing rates up to more than 20% so far, and hopefully more after that. Does it reduce prevalence? Well, that's what we'll know in the next year, because the final surveys are taking place. We have our fingers crossed, and we will see whether this is able to show a reduction in transmission. Just to mention that there are other screening programs in place. This is one that you'll probably be familiar with. It comes from, it's in England. It's called the National Chlamydia Screening Program. It's also opportunistic. This one has been in place for more than 10 years now, rolled out across England. And one of the interesting things, it's very similar to what ACCEPT is offering. And it has achieved uptake across the country of around 25%. That's of all adults, not just sexually active ones. But interestingly, measuring PID incidence or measuring chlamydia prevalence were not included in the outcome measures for this program. So it's very difficult to know what has happened. Fortunately, the National Survey of Sexual Attitudes and Lifestyles did a survey at the start of chlamydia screening and did one last year. So we looked at what the prevalence was. Now here, I'm going to show you in that cell in 18 to 24-year-olds, which were the comparable age groups, this was the prevalence estimate in 1999-2000, and this was the prevalence estimate 10 years later after 10 years of introducing a chlamydia screening program across the country. They are ecological data because they're related at the population level. We cannot infer any causality, but I think that's interesting to have achieved very, very high coverage of chlamydia screening, but at the population level, the prevalence has remained very similar. Now, to bolster that, these are the results of the Netherlands trial, and in the US, rather than doing surveys with a 10-year interval, they've actually done them in 2-year intervals. And in the same age group of women, there has been some ups and downs on statistical uncertainty, but overall, not a major impact. Now, the thing that I'm going to come to close with is to harp on again about this repeated infection business. If we're going to do chlamydia screening, we think that we should. Most of these recommendations say that you should have a screening test every year. Well, how frequent is frequent enough if we know that, again, women are going to get reinfected, 25% are going to get reinfected after a year? This study, an observational study, about 350 young women in Indiana, I find absolutely extraordinary. They screened all of these women every 3 months, and they treated them if they were positive. So if you're screening and treating every 3 months, you would expect to have a major impact. Now, these are young women from disadvantaged places, but I challenge you to say that there has been a convincing reduction in the percentage of those women who are positive at the beginning and at the end of 5 years of following up these women. They became reinfected quickly after being treated. And I think this should have a major, major impact on the way that you think about what good you're doing when you're screening and treating someone. So final conundrum is that the trials show that PID can be prevented by chlamydia screening and treatment. And actually, PID rates have been falling in many, many countries over the past 30 years. And so, but we haven't seen very much impact, we think, on chlamydia prevalence. So there's now a question about, can you have a sort of disjunction where chlamydia screening reduces PID, but doesn't have an impact on transmission, probably because of reinfection? And the immunological hypothesis is that by early treatment, you're preventing the infections that would cause the tubal damage. So yes, you can prevent PID, and therefore you should do chlamydia screening, but you may not have a substantial impact on prevalence. So that's the sort of current thinking. And I just thought that through a little bit, and with 2 particular programs in mind, or places in mind. One was British Columbia, where Bob Brunham and Mike Reckart have proposed this hypothesis and give this decline in PID and an increase in chlamydia diagnosis in support of it. But then I came to some familiar data from New South Wales, way before there was any major effort to roll out chlamydia screening, so from the early 90s. And hey presto, PID was already reducing at that time, and probably had been reducing from before this time. The common feature both these places have is that gonorrhea does not explain the decline in PID, because gonorrhea rates were already low in both of these countries. So, and the more cautious conclusion by Marcus Chen and his colleagues was that testing rates appear low, and that you should draw conclusions from these data very, very cautiously about whether there would be any impact of chlamydia testing on PID. But this is a hypothesis that's going to be researched more and more. Right, I'm going to finish with some conclusions. Firstly, we've seen that chlamydia rates vary widely internationally. But overall, the probability of becoming infertile from a chlamydia infection is probably quite low. We've seen that chlamydia screening can reduce PID, which is the immediate proxy for infertility, but hasn't yet been shown to reduce chlamydia transmission. And repeated chlamydia infection, I think, is probably quite a good candidate for limiting what the impact of any current chlamydia screening interventions that we have. So The relationship between PID rates and chlamydia screening and chlamydia infection itself, I think still, we have to say, still remains unclear. Finally, what are we going to do in the future? We need to have the results of these ongoing trials. And we need to look at these countries, like those in the South Pacific, which have very, very high prevalence, and with our available tests and treatment, people are going to want to intervene in these by saying we must do something about high prevalence rates. But we really have to weigh the evidence about whether wading in and doing a mass screening and treatment program is going to do more good than harm, especially if it's not sustainable. And so the benefits of chlamydia screening, I think, are not yet shown to outweigh the harms. The big drive, and I think where the investment is now, is in chlamydia vaccine development, which is ongoing several places. Bob Brunham in Canada is doing it, and it's going on here in Australia. By all accounts, Andrew Craig and David Wilson say that 5 years of a chlamydia vaccine in koalas is going to reverse their decline. So maybe we can do that the same for people. I just want to finish with this. I'm not quite sure which is the koala, because I think Peter Timms is looking more and more like some of the animals that he investigates. And with that, I'd like to finish and say thank you.